about that on Monday, and you do have access to the raw textbook. And just a quick review, what you're visualizing on an image are the surfaces that's just the opposite of the view itself. You with that? So when you just use the word dorsolateral, you know that you're looking at the opposite surfaces, the dorsal medial. So you can quickly, in your head, get that, and then you're looking at on the caudal surface, just the opposite of the V. Okay, so I think we all got that pretty good. We talked about the L lateral. L matches the second letter L, lateral oblique. So you're actually looking at the palmar, a plantar-lateral surface. And remember when you call the view, it's a 360-degree circle based on the entrance and exit of the view. Okay, great. Don't forget, intermediate before or proximal to radiocarpal. So you therefore can look at all of the surfaces of the intermediate and radiocarpal bones, because those are two bones commonly involved in chip and slab fractures. So I'm not going to repeat all the information that you covered in equine, because they are the experts. I'm just going to cover these common conditions that you need to know. Any veterinarian should know, whether you're large animal or small animal. Common fractures, what osteochondrosis look like. What's the difference between osteochondrosis and osteochondrosis dissecans? Degenerative joint disease. Osteomyelitis is sequester formation, and why is common on the cannon bone, navicular disease, pedosteitis, and laminitis. Another very quick review, proximal and distal row of carpal bones. Proximal row, use your fist, so the articulation is right down the center. And then the distal row, the articulation is off to the side or lateral. And that's how the view is taken. Okay, common fractures. Chip fractures involve one articular surface. This is a quick review. Slab, two articular fractures. Chips, they can remove. Slabs, if it's bigger, if they're large like these, they'll have to put a screw in. So chips and slabs. Chip fracture involve only one articular surface. Slabs involve two articular surfaces. It's pretty easy to know. Proximal sesamoid bones. I talked a little bit about this on Monday. Radiographically, you can tell the difference. Sometimes it's different between the front leg and the hind leg, and the appearance of the abaxial surface of the proximal sesamoid bones. So the latter one appeared to be taller. Just remember one, and then the other one, of course, is just the opposite. The medial one is a little bit wider along the abaxial surface. Kind of looks like a D shape, but not all the time. You can just look at the lateral and see where it's indented, concave along the lateral margin or abaxial margin. Again, it varies between breeds of horses. It varies from front limb to left, from hind limb. But if you happen to have a view and it looks this nicely projected, you can make an assumption that the one that has the wider abaxial surface is medial. You already know this. They're the proximal sesamoid fractures. This is how they classify them in 6 different types. Okay, good. Now, apical is typically very common, and is involving the apex of the proximal sesamoid bone, and then of the abaxial is of course along the abaxial surface. Axial is down from proximal to distal. Transverse is medial to lateral. Basilar is at the base. Those are most difficult to get to. And combat movement, of course, is in multiple pieces, segments. So now I have a question for you. This oblique view here, both of these are oblique views. This one just confirms that the proximal apical fracture of the proximal sesamoid bone here is projected on the oblique view here. But let's talk about this one. That's a transverse fracture of the proximal sesamoid bone. This is, I'm going to give you the view and you tell me which sesamoid bone is fractured. Okay, everybody ready? Mm-hmm. This is a dorsal medial palmarolateral. Dorsal medial palmarolateral root. Which sesamoid bone is fractured? Okay, right here. This is individual, just writing on some kind of piece of paper. If you're studying for something else, please go to the library.
What?
Okay, this is individual. Put your name on it. This is the dorsal medial palmarolateral root. Ready? Little pieces of paper is good. You make some? Oh, okay.
Are you asking what you were looking at?
I want to know which sesamoid bone is fractured. Which that's a transverse fracture of the proximal sesamoid bone, right? It's a transverse fracture. Which one? Which one? If you have two, median or lateral, which one? I got it. I don't mind bringing it down, and I don't mind repeating. I don't, because you got to get it. And I'm going to tell you another shortcut. For those students that said it right away, you probably know that shortcut already. Make sure your name is on it. Huh? No, it's a transverse right there. I'm telling you that. Okay, here we go again. I don't need you to tell me that it's transverse. I'm telling you that it's transverse fracture. I need to know which sesamoid bone. There are two, right? A median and a lateral. Which one is fractured? Anybody else? Oh, so much fun, fun, fun. Now guess what? So this is what I'm going to do. So I'm going to compare what you said today on what you're going to have on the exam. Because if you're going to be on the exact same question, you're going to be on the exam. That's pretty fair, isn't it?
Yes, ma'am.
It's going to be the exact same question. But it's going to be the exact same question. Listen. It's going to be but if you don't get it today, you're not going to get it. It's going to be the exact same question. That's it. better. Okay, got everybody? So which says no?
Has everyone given their pages?
You don't need to do anything but relax. So which one is fractured? Medial. Is that second letter? Someone doing this in my head yesterday. Now they want to do it in my head before it's here. So this is the dorsomedial palmarolateral. So it exited on the palmarolateral. So you're looking at the opposite, which would be medial, which matched that second letter, which is medial oblique. How about that? Okay, so how everybody got it? No? Okay, so if we're still struggling with that, at the break, I'll go through it again. Just meet me right here. I'm not going anywhere. Okay, good. See me at the break. Can you see me at the break? I'm not going anywhere. And you get the individual attention. How about that? Our next R&R. Our next R&R. Oh no, you do. Okay. Sorry. Well, you are invited. The next R&R is when, Dr. Gillespie?
27th.
November 27th. Okay, osteochondrosis. Osteochondrosis is a term that they use for cartilaginous defect. When we use the term osteochondrosis dissecans, that usually means dissecans, desiccated piece of bone. And you typically see this in small animals. Desiccated, dry, dead piece of bone, dissecans, would be a fragment from the osteochondrosis concept, osteochondrosis complex. In horses, it's just referred to as osteochondrosis. If you don't see that fragment or piece of desiccated bone, that's why they just say osteochondrosis. I talk about this more with small animals. Is because it can have a fragmented, desiccated piece of cartilage, but you don't see it radiographically because it's cartilage. But when you see it, it's calcified, and then we call it desiccated. So because you don't see it radiographically, then we use the term osteochondrosis. Common locations: the distal tibia, more commonly the intermediate ridge. Dirt. Just a dirt lesion. Everybody have their own little. Actually, I went. Thank you for Dr. Carter for looking at Louise. Those. I actually saw that. But I just can't even pronounce it, so I'm probably not going to use it. But if I hear it again, I know exactly what you're referring to. Okay, so these are the common locations. And so what you see is a radiolucent line, which is where the cartilaginous defect. You might see flattening or irregularity of the trochlear ridge of the talus because it's cartilage. So the cartilage has not calcified, then it looks flat. Because cartilage is still there, it just hasn't calcified. And any osseous cyst-like lesions, they also refer to as osteochondrosis. So what do they look like? So which view is this? See where A is? Which view is it? Okay, on my right. Students on my right. Which view is it? Everybody see my little marker, my little pointer? Which view is that on my right? Medial. Medial what? Medial. Okay, if you don't say medial oblique, I'm just going to assume you're saying medial, which is a lateral view. Everybody got that? Oh. Okay. Yeah. If you just say medial, the beam went from medial to lateral. If you say lateral, it's the same thing as a lateral. Because typically the beam goes from lateral to medial. If you're telling me it's the lateral surface of medial surface. Everybody got that? So you all say medial bleed over here? What'd you all say? So some of you all are saying, okay, notice these are same, these are gonna be the, you see these views right here? They're gonna be the same one. I mean, how many ways can you ask? Which view is this? They all kind of look alike. So then, whose nose is this? And so which trochlear ridge is that? So smart. Okay. And then you see the flattening and irregularity of the ridge of the talus on that one. And obviously this is a lateral only because here's your little L. Okay, your little stair step. This one does not. So that's medial. Straight down. That's correct. Okay, degenerative joint disease. Now, equine people get just disturbed when you call an osteophyte and enthesiophyte. So in these, they all look alike, radiographically, because it's a tendinous pool or capsular pool, and then when that happens, you get osteophyte formation at the articular surface. If it's located at the attachment of a tendon or ligament, then they call them enthesiophytes. Not to be confused with osteophytes, but radiographically they look the same. So degenerative joint disease, of course, just like any arthritis, the joint spaces are narrow because there's decrease in synovial fluid. And what happens when there's decrease in fluid? Then the stress would be on the bones adjacent to the joint. And then they become more compact rather than porous. And then that is referred to as subchondral sclerosis. That means the bone that you're looking at is more opaque and it's absorbing the stress rather than the joint itself. That's a really good clue to joint disease or degenerative joint disease. Works best in both large and small animals. Question. Okay, osteomyelitis is sequestrum formation because the cannon bone has such a thick cortical surface, and people that call them marching fractures or march fractures. And so when there is a fracture fragment and there's not very much blood supply because of the large cortical bone, it's fine to be resorbed if it doesn't get infected. So if you have a soft tissue component and then there's infection, now the fracture fragment becomes the nidus or the sequestrum, the infection around it, and the developing draining tracts. And that's what it looks like. In some books, they still call it the involucrum, which is the subchondral bone that is actually surrounding, trying to wall it off. I haven't seen that word used in a while, but if you happen to see it, it's still part of the osteomyelitis and sequestrum formation. These are very easily seen. Obviously, you see the fragmented piece of bone, which has lost its blood supply, because if it still had a blood supply, it would be resorbed, right? It will be resorbed, go away, infection go away, put it on antibiotics. But this one will not. You've got to go in and move the nidus of infection. Okay, you have to remove the sequestrum. Navicular disease. This is a normal one. This is increased vascular channels in B, and they're referred to as lollipops, mushrooms that are along the ventral margin. And that's just a typical example. Heteroosteitis, normal, there's a smooth surface. Look at the normal large number of vascular channels. And then what does that look like radiographically? It becomes very irregular along the surface of P3. And you all can see the difference in that. So there are some cases you have a little bit of irregularity as the animal become aged, but not to the degree where there is such an irregularity, concavity description along that surface. So keep your eyes down. And just because you see the radiographic finding, does that mean that the animal is exhibiting signs of? I got that because if they're on hard surface, you might see that and it might not be clinically significant. So all that come together with the clinical signs. And the very last condition, everybody knows laminitis. Okay, separation of the lamina. There's theories as to why the air segments between the two areas, between the hoof wall and the corium. And I listed those. Air dissected from possible necrosis through the coronary band of the soul, or there's movement of nitrogen from the blood itself into a potential vacuum that's created by the displacement of the toe. And everybody remember the horse that broke its leg? Starts with a B. And then he developed laminitis, and that's what actually got him, was that. Actually, I was at Michigan State at that time. I had a chance to look at the radiographs, actually.